Hello and welcome to That Implementation Science Podcast, the show that aims to reduce the innovation to implementation gap to 16 and a half years. I'm your host, Mike Pullman, and on today's show, co-host Kevin King and I will interview Stephen Schueller. We'll talk about digital mental health apps, the challenges and benefits of doing implementation science work in a digital landscape, the implementation factors worthy of consideration when conducting digital mental health research, and chocolate and broccoli, but not chocolate-covered broccoli. Best of all, Kevin and I get Stephen started on an amazing rant about Johnathan Haidt's book, The Anxious Generation. Let's get started. Hello, everybody, and welcome to That Implementation Science Podcast. Today, we're here with Dr. Stephen Schueller. He is an associate professor of psychological science and informatics at the University of California, Irvine. His work focuses on improving access and knowledge about effective and scalable mental health treatments, especially through technology. He develops, evaluates, and implements digital mental health assessments and interventions through websites, mobile apps, and wearable devices. Welcome to the show, Stephen. It's good to see you.
Happy to be here. Long-time listener, first-time caller. So happy to be here with you guys.
Awesome. We're going to have to move our fan club up to 3 people now. This is good.
3 people? Oh my gosh. We're going to have to get a new website for that. They're going to crash our server.
Yeah. I was looking at your bio and I saw that you're a father of triplets. Is that right?
I do. I have 8-year-old triplets and I've made it this long. So far, so good.
Oh my goodness. I don't know if you know this, but I have twins, 8-year-old twins. And then
I didn't realize that.
Yeah,
pretty close in age. So you know the experience of the age they're at right now.
Yeah, so my goal was to always have twins. I always wanted to have twins, but I wanted to have them first and then not have to have children again after that. But you ended up with even more, but you had 2 bonus children.
There was 30 seconds where I thought I was having twins, and I was really excited.
Yeah. I bet are any of them identical? Sometimes that happens, right? You'll have one.
No, and anything can happen. You could have all identical triplets. Right. You could have identical twins and a fraternal, but all of ours are fraternal. They all look quite different. They're their own little people, and it's a real fun age to have kids right now. Yeah,
well, as a research psychologist, I always wanted to have identical twins, which I had, so that I could do experiments with them all the time, and I do that all the time. But they're turning out exactly the same.
Yeah, whenever I have to give people parenting advice, I always just mention I have really good statistical power compared to what they have with just one kid. So all of my stuff is evidence-based parenting.
The problem, Stephen, is everything that you do is confounded by age period cohort effects. It's a real challenge. If you had kids spread out over time, it might be easier. But I guess you're really excited about that longitudinal cohort design, huh?
Well, or I can try to convince my wife to have another set of triplets, but I don't think that's going to happen.
I think you try to get a stepped wedge design in here with another couple sets of triplets.
There we go.
Talk about needing funding for that, huh?
Well, Stephen, it's so nice to have you here today. I know you do a lot of work in digital mental health, and so we just wanted to start off with you maybe telling us a little bit about what the current state of the science is on health apps for children and others around to address mental health issues.
Yeah, well, I think there's a lot of mental health apps that are out there. I think it's been an area that there's been a lot of interest in the research field and increasing interest in venture capital funding and different health system settings really trying to try out these tools. Real challenge is that there's a wide variety in the evidence base, and very few of these tools are actually backed by scientific evidence. And I think it's really hard to figure out then what tools work and which tools are not backed by evidence. And I think, in the place that I think all of us are sort of thinking about in terms of implementation science, there's not a lot of instances, at least in the States, about where these tools have really caught on and been used. I think we have some good examples around the world. In the UK, they're doing a lot of this in the Increasing Access to Psychological Therapies, or IAPT program. In Australia, there's a lot of use. Nick Titov has really been leading a lot with his MindSpot clinic. But here in the States, a lot of these things are just sitting on the shelves or sitting in researchers' offices, which I think is one of the unfortunate things we see a lot in implementation science.
Yeah, is there any, I know in other countries as you mentioned, there's been some increased uptake and even having, insurance coverage for some of these apps, or a doctor can sort of prescribe an app. Has that taken hold anywhere in the US yet?
There actually has been some legislation that's been sitting in the Senate for a while, that's focused on thinking about reimbursement for FDA cleared products. I think a real challenge is that if you have to think about who's going to pay for them, you also have to think about how you separate the good from the bad. Like, what are the things that it should actually be paid for? And I think that raises some really challenging questions we haven't sorted through, at least here in the States, about how to do some of that vetting. In some other countries, like Germany, for example, they have this program called the DIGA. I forget what it stands for. It's a very long German word. But essentially, it's a framework for how they think about what tools should be considered for further evaluation. And if they pass then that evaluation benchmark, they go on to reimbursement.
Oh, that's fascinating. And that seems, from an implementation science perspective, where we think about those external factors and policies that might drive uptake. I sometimes think of that as being just probably one of the most powerful ways to get interventions into the hands of people. And I've already seen some, I think maybe you and I have talked about this a little bit in some of our own research. I work with this company called Talkspace. They provide remote therapy, and they can do that over video, or they can do that over text, just by pure texting. And when it was private pay, mostly, over 90% of their customers did text-based therapy. That was their preferred choice, right? Great. They still had the same levels of working alliance, good engagement, et cetera, compared to video chat. But they've, over the last couple of years, they've switched largely to a business-to-business insurance-covered module, and insurance doesn't cover text-based therapy. And now it's flipped. Like, in the course of like a year and a half, it flipped from 90% of their business was text-based to 90% is video-based, even though, as they've seen, people actually seem to prefer text-based. And so those policy decisions just can be massive, massive drivers in the way that people use these services, and in what services are available to them.
Yeah, and I think if you look across implementation science, a lot of the work, like we use the consolidated framework for implementation research as a frame. A lot of the work that we do as researchers typically is in the inner setting domain, or the innovation factors domain, or the implementation process domains, because I think those are some of the levels that we as researchers can more easily do our studies on. But I really think a lot of these kind of outer setting factors and more contextual factors really drive a lot of these success or failures of these implementations. And I think we have to better understand those outer setting factors and in more nuanced ways.
Stephen, I'm wondering, could you maybe talk about the lay of the land of mental health intervention apps or digital apps in the context of, what you're talking about so far are things that are evidence-based, things that are research, developed out of research labs. But it strikes me that this is a little bit like the nutritional supplement field, in that there's tons of things that people can download that are purported to be mental health apps, mental health interventions, some of them even developed by the big tech companies. Could you talk about sort of the differences, or even just give us a sense of the landscape of what that looks like?
Estimates suggest there's about 15 to 20,000 of these mental health apps that are out there. And definitely if you go to the Google Play Store or Apple's iTunes Store and put in depression or anxiety, you will get a lot of hits. And the other thing that I think is a real challenge is if you put that in and you go to those stores, most of them are going to have like 4.5 stars. So there's like no information to the consumers about like, well, what are the good ones and which ones should I decide? Very few of those have any scientific evidence backing them. So about 3% of them are maybe evidence informed. They're based on evidence-based principles, cognitive behavioral therapy, mindfulness type practices. Only about 1% of them have any scientific evidence supporting that product itself. And so I actually hear that a lot as a argument against this field of like, look, 1 to 3% of stuff is evidence-based, so, we should just throw it all out. And, my point on the flip side is like, well, if there's 15 to 20,000, that means there's like maybe 150, 300 evidence-based interventions that are scalable and deployable and available to people. And that's awesome. That's great. And if we can really get those out there, I think in the reality of a lot of these implementation settings, we're really thinking about kind of that more upper tier, upper echelon of the products that are more evidence informed, at least based on some of these more standard practices that go on in psychological therapies. I do think there's still a question of like how the results from those research studies or other evaluations that have been conducted on those, how they translate to real world settings. And I think, the point you were making, Mike, about how sometimes we see some flip in terms of how these products might have been used under those initial evaluation settings to the deployment settings, I think is a really interesting question about then, do we get equal benefit when those things happen? And I think that's something that we have to think about. But I do think that most of the time we see these things implemented, it is a smaller group than just the things you might see in the app stores. Where I really encourage people to look to is to see if you have insurance, possibly maybe your insurance provider might provide some of these tools for you. I actually, as part of the insurance that I get provided from the University of California, I have access to a digital cognitive behavioral therapy platform called MyStrength that I can go and use. Kaiser Permanente has a couple different apps in their suites that they've made available to their members. Some are mindfulness, some are cognitive behavioral therapy apps. In state of California, there's actually been a big project over the past couple of years that we've been evaluating called Help at Hand, where they're deploying some of these tools in different counties and in county mental health services. So I think there are some examples of some things that have been rolled out, but I do think it's a smaller subset of the broader area of digital health.
And it seems like one of the things you're pointing to is that, at least right now, the sort of structural solution to getting effective things out there is not through app stores, but it's through entirely different channels, like you're saying, insurance companies, through, if it's in the UK, or like through national health systems, through your doctor's office, through referral networks, something other than somebody is sort of feeling blue, they're thinking, I want to learn about reappraisal, and I'm going to go on the app store, because that happens all the time. So I just find that interesting, that it's sort of one of the arguments is, let's just end around where people might typically look for this. And maybe the argument that you're saying is we're going around where people might look for an app, but we are going through the channels where people might look for help when they need it.
That's right.
Yeah, I'm sure there's some legitimacy lent to the apps when it's endorsed by Kaiser Permanente or some other health provider. And also, I imagine that comes with a little bit as a double-edged sword, because as we know, with any kind of approval or certification process for any kind of healthcare product, there is business aspects that occur that we're not privy to, right? And so how much is why we tend to put our faith in something like the FDA, supposed to be independently reviewing research, as opposed to relying on a drug company to create a deal with hospitals, which we know happens all of the time, and those hospitals then give us their preferred medicine. So I imagine the same thing might occur as well in apps. I don't know if that's something you've thought about at all, Stephen.
Yeah, there has been some FDA approvals and clearances, I should say. There's sort of different, there's FDA clearance, there's breakthrough designation, and there's like formal FDA approvals. And all of those things have been going on in the app space for about the last 8 years or so. The first product that was cleared by the FDA was a product called Reset by Pear Therapeutics, which was for substance use disorder. And essentially, it was built off of a lot of research that Lisa Marsh's group had done for years at Dartmouth, and Pear Therapeutics worked with that team and commercialized the product and got FDA clearance to be able to start to try to market that product. Now, Pear Therapeutics has gone bankrupt in the recent years, and so I know some of their assets have been bought up by other groups. I actually don't know if Reset was purchased by another group or not, but I think we've seen a little bit of FDA involvement, but I would really emphasize a little bit. And I think there's been two things that have really slowed it down. One was back in 2020 with the pandemic. We may remember March of 2020, or we may have blocked it from our mind, much like I've blocked the early years of raising triplets. But the FDA actually paused the regulation of digital mental health products because they said, like, look, our assessment of the risk-benefit ratio is that the risks are probably not that high. The benefits could be massive, especially at this time when there's a huge need and we can't go get traditional face-to-face services. And so go for it. You guys can market your products to people without FDA clearance at this point. And there were a couple companies that went out and did that and started to market their product. And they had to say, we haven't been cleared yet by the FDA. Under this guidance, we're allowed to do this. That's been rolled back, and I think we're still seeing what the implications of the rolling back of that were. So I think that that's one thing that has been sort of really interesting over the past couple of years that's made a little bit less guidance. The other thing that's made the guidance here a little more light is that there's actually sort of three subsets of places where FDA is operating, or I guess could operate. So there's some products that are not medical devices. If it's a wellness app, if it's, targeted towards happiness or well-being, or it's improving your productivity, that's not a medical device. And so FDA doesn't regulate those things. And so any of these kind of wellness apps or things that would be sort of mental health apps as we talk about them that are thought about as wellness products, those are not regulated by the FDA. There's another subset, which the FDA has said that they're exercising enforcement discretion over, which means that they say, well, we could regulate it, but given our assessment of the risk-benefit ratio, we're deciding to not do so. We are exercising enforcement discretion. And a lot of the stuff I think that we, are interested in, or, I'm interested in as someone doing work in this space, kind of falls in that enforcement discretion bucket. It's stuff that says, for example, that allows a individual diagnosed with a mental health condition maintain behavioral coping strategies through tips of the day or other interactive exercises. And that's created this little bit more of a gray area in terms of, is this an enforcement discretion app, or is this a product that actually needs formal FDA approval and clearance?
It's interesting, the designation of sort of well-being. It makes me think of the statement you hear all the time that this product is not intended to treat, cure, or prevent any disease. I almost wonder if we should have that disclaimer across the top of all positive psychology papers, because it seems like that's also describing the field of positive psychology. Like let's just talk about well-being. Let's not talk about illness and badness and disorders.
Well, I don't know if you dug enough into my background, Kevin, to see that I was initially, and still, I guess, am a positive psychologist. I actually got my start in research doing work on positive psychological interventions. I did my grad work at Penn with Marty Seligman. So I have a lot of background in thinking about sort of happiness promoting interventions.
Yeah, and it's just this interesting. I find it interesting that there's this sort of dichotomy or a continuum where at some point we start thinking like, okay, people thriving and people's well-being, we're not going to so much worry about that in terms of like FDA and regulation. Yeah. It also reminds me a little bit of coaching, right? Coaching is sort of like the nutritional supplement of therapeutic interventions, as in I'm not trying to help you, recover from something or treat some kind of disorder. I'm trying to help you thrive and be better. And we decide, I don't have a stake one way or another on that, but it seems like we're sort of a lot in that space for
yeah, well, and
a bunch of things. Yeah.
What I find problematic about the space actually is a lot of products position themselves that way, I think, to avoid FDA regulation. That's my assumption. This is why they're doing that. And they'll say, on the advertising or on the app store, this is not meant to treat depression. This is a wellness product. But then you get into the app and it's like, okay, now let me tell you how to treat your depression. And so I think there's a little of a bait and switch that goes on in some of these products as they sort of position themselves as wellness products to fall into that less regulated category. But then when you really look at the nuts and bolts of it and like what's on the inside, they're promoting things that seem to be suggesting that they could help alleviate these mental health conditions.
Yeah, jingle jangle fallacies, they're everywhere, I'd be curious to hear, what do you think? You've already sort of talked a lot about a lot of these things, but what do you think are other sort of major barriers for adoption for digital mental health apps?
I think reimbursement is the biggest one, honestly. It's like someone has to pay for it. And what we find from consumers is that their most desired price is zero, free, especially because of this aspect of because I think consumers have less appreciation for what is the nuances between these products that are on the App Store and the products that maybe come from other places. They look at the things that are on the App Store and they're free. And it's like, well, why would I pay X amount of dollars for a depression app when I could go to the App Store and find 100 of them that are free? So someone has to pay for it. I think the question is, as we talked about, how we decide which things should get paid for, and then also what's the price. And I think the pricing aspect has been a real challenging aspect of this in terms of thinking about, how much of the value, if a company, for example, develops a product that doesn't have a human involved, how much of that saving gets passed on to the purchaser or the consumer versus a product that does have a person involved where you have to pay for some aspect of that person's involvement. I think also like what you pay for. So the American Psychological Association has actually been doing a lot of work working with app companies and legislatures and other stakeholders to try to figure out how might these tools be reimbursed. And they have a model that I really like in that they sort of think about there's three things that need to get paid for here. There's the time it takes to set someone up with one of these tools. There's the tool itself, the product, and then there's the human support that's provided through this intervention. And at least it jives a lot with what I've seen in my research because it does take sometimes a lot of work to get people, well, maybe not a lot of work, some work to get people onboarded and ready to use a tool like this. Digital literacy training, technical assistance, just making sure, it works on different devices. So I think that takes time, that should be reimbursed. Obviously, the people who are developing these things should get paid for the products, and then the human support around that is a service as well. And I think that one of the way that some of these products have thought about trying to fit into reimbursement pathways is there's a current billing code that's for remote patient monitoring. And so there have been some attempts to try to use that billing code to pay for these tools. But it's worth noting, like, we're not monitoring patients through these tools. We are actually providing an intervention. And I think that's why I like this APA thinking of that those human support services, be they coaching, be they psychologists, be they something else, should be something that should be reimbursed, and that those sort of three buckets seem to be the important elements of where value is being added to the system.
Yeah, it's an interesting issue because implementation science has traditionally come from a perspective where the thing that's being implemented requires this professional to deliver it. And we've had some interesting conversations. An episode that's either come out recently or is going to come out soon after this one will be a discussion among many experts in implementation science who could not agree upon this issue I'm about to describe, which is, what do you call an intervention and what do you call an implementation strategy when it's a self-help kind of intervention? Many of these digital mental health apps are interactive. They are, but they're self-delivered. They don't actually go to a professional. No one actually ever reviews these things. And so are these strategies or are these interventions? I would call them interventions. And I think sometimes, too, the typical way that we've reimbursed for mental health services has also relied on this same kind of model where we're kind of focusing on professionals. Now, this presents some interesting issues for implementation. So digital mental health apps could be modified at any second and distributed like that, faster than the McRib goes out, which is a new, which is a wonderful way of thinking about implementation, right? How do you get a bunch of people to do something new all of a sudden, with therapy, somebody develops a manual. That manual is a book. The book takes a while to change and modify. You train people, you bring them up to fidelity on this. With these apps, maybe the FDA gives a clearance and approves an app, and we know that it works, but then it can be changed and modified at any second. We don't know what's effective, what's not. I'm just wondering if you could offer some reflections on these thoughts, both the benefits and the drawbacks of digital mental health in around these types of issues.
Yeah, well, first I'll say I like the point you brought up around whether digital mental health apps are a thing or an implementation strategy. And I've been in that conversation and had that debate with multiple people, Brian Mittman being one. We've talked a lot about this sort of issue. And I think one way that people are seeing this is like digital mental health is an implementation strategy because the thing is cognitive behavioral therapy. And the way we get people to do the thing is the app. And I'm really of the belief that these digital mental health tools are the thing that need to be implemented. They need implementation strategies to get them out to places. We can't just put them out there in the world and people will pick them up and use them. And so I think that I've really been conceptualizing these things as the thing. We need implementation strategies to help get these into the hands of folks. I think one thing that has been a little bit of a challenge, and I'm maybe biased because I am a clinical psychologist, is that when we think about FDA approval, the then way that people have been thinking about distributing these have been following a pharmacological model, so that a provider with prescription privileges will have to be the one who is prescribing a digital mental health tool to their patient or their client. We built these things as clinical psychologists. We know the contraindications. It's not, I don't quite understand why an MD has to be the one who gives you a digital app. I mean, I understand why I can't prescribe people Prozac. I don't know the drug interactions, and I'm not trained in biochemistry in the same way. But again, like, we as psychologists, we made all these things. And so I think like that's something that's been an interesting way to think about this. One thing I've heard in some places is that there's a little bit of like competition, perhaps, aspect, is that on the flip side is also, we made these things. I could also give this intervention. Like, I can give someone cognitive behavioral therapy. I'm trained to do it. Why would I give you an app to do that? But if you're looking at a prescribing physician who's a general practitioner, they weren't. And so it's actually kind of appealing to them to sort of think about, like, here's a product I can give my client who's complaining about lack of motivation and they're not sleeping well and they've had these thoughts about harming themselves, and here's a tool that might be able to help them overcome that. Let me give them that tool and see if it actually helps. So there are all of these aspects that come up that I think are really ripe questions for implementation that I think really need to get solved to be able to get these tools in the hands of people who could benefit from them. Contracting, that's one I've gotten really interested in and just seen as like such an important barrier to the implementation of these tools, because settings that are trying to use them, they're used to setting up contracts with providers, and it makes sense. But now they're trying to set up these contracts with health technology companies, and it has to go through the IT department, which they don't know the IT department people. So then it goes and disappears there for months on end. And there are questions that come up that they don't know the answer to. And so I really think like those aspects have been some of the things that really have slowed the implementations of these tools. Greg Ahrens is someone who has brought to my attention the importance of contracting and everything related to implementation. And the more I've seen some of these deployments in different settings, the more I've really been convinced that aspects like that, contracting and training and enthusiasm and leadership buy-in, those are the things that we really need to think about if we want to try to put these digital mental health tools into real world settings.
I'm confused because every time I've read a grant or a paper about, just-in-time adaptive interventions or scalable digital mental health, they're always making the promise that we can just develop these apps and then people are just going to take them and use them and it's going to sort of solve, all the world's ills with this. You're saying that this is just like any other intervention, that we have to pay attention to settings and contexts, and we might even have to think about implementation factors for this to actually work. Just feel stunned, Stephen.
I know, it's just amazing that this is such a unique area that if you build it, they will come and they will use it and they will take it up. And we found the one place where train and pray actually works.
Yeah, I mean, yeah, it's remarkable how easy it is. I mean, I can say this personally, how easy it is for me to buy into this idea. Oh, this is totally scalable and this is totally, you could see this, just put this on the internet and everybody's going to use it. It's going to be the Angry Birds of CBT, it'll just get out there. And yeah, the thing that strikes me as you talk about all of this is that I think, all of the ways that a digital mental health intervention doesn't fit with the current system, it makes me think, well, of course it doesn't fit, because the current system's developed along, like all the policies, all the billing, CPT codes, the leadership around it evolved along with the interventions. And so when you have this intervention, it sort of evolved with face-to-face CBT, and we redesign systems to pay for and make face-to-face CBT work. And so if we're like, hey, now we have CBT, so to us it's the same thing, but it's in an app, or at least the fundamental processes are the same. What you're clearly outlining is like it's not the same in any way to the systems, right? And I mean, this is just my impression, my reaction to that, but it maybe thinking about the coevolution of the systems with the interventions highlights the need to think about it from a systemic perspective, like you're saying. It strikes me that I was just incredibly naive, which I have not. I've been accused of many times in the past, so not surprising to me.
Well, and Mike said something earlier about this potential direct-to-consumer model, which I think is really interesting. We actually have a funded hybrid type 2 design funded by National Institute of Mental Health, where what we're evaluating at the implementation strategy level are two strategies, one of which we're calling inReach and one of which we're calling outreach. And we're implementing a digital cognitive behavioral therapy platform for monolingual Spanish speakers. And so those inReach versus outreach strategies, inReach is sort of traditional warm handoffs. We're going to the providers, we're giving them some instruction about this is what the program is. You can make it available to your clients who speak Spanish, who are experiencing depression, anxiety. For outreach, we're going straight to the EHR and we're looking at all the data about, who potentially might have depression, anxiety, and we're going straight to them and emailing them or sending them MyChart messages and saying like, hey, we have this program that might help you. Your provider said, it might be a good fit for you. Would you be interested in signing up? And in that outreach condition, we're going to have a huge funnel. We already see this. We have a lot of people and we're screening them. And in the inReach condition, we'll have a smaller funnel, but maybe when you have that warm handoff coming from your provider and they're more involved in the process, it might make you more likely to uptake and actually stick with the intervention. So who knows? We'll see. But I do think like thinking about the implementation strategies that might be specifically well suited for digital mental health is where we need to be going in sort of the next phase of research, which is one reason we're looking at it in this current trial that we're conducting.
Well, I'm going to shift gears a little bit. I'm kind of curious about, we haven't spoken a lot about research methodology. And I know this is something that Kevin and I both get super excited about. And I imagine there are particular challenges. I know that we've faced some in our own trial, and also really major benefits when conducting digital mental health implementation science research. I'm curious if you could talk a little bit about what you see as some of the strengths and weaknesses.
Yeah, I think that there's a real challenge, especially now, around fraudulent participants. I've heard this in a lot of studies of folks that I've been talking with who've been doing remote studies, and it feels like it's been getting progressively worse. I think when I started doing digital mental health work, like 20 years ago, we could put things up on public forums, we could reach people in different ways, and we would have real people come to us and use these interventions. And I think now we see a lot more of bots or other people who are trying to participate in research projects for the financial incentives that often come with doing those assessments. So I think really thinking about how we get real participants. I think that there's just been a growth of interest in using these different survey platforms, and I'm getting increasingly skeptical of some of the research that is only using online recruitment to try to bring in some of these people. I do think one thing that's really cool about digital mental health, and actually this is what transitioned me from doing positive psychology interventions to doing digital health stuff, is I was really interested in person activity fit. So how could we create sequences of interventions to be able to benefit particular people? And the cool thing about digital is that interventions could be very modular and we could provide them to people with perfect fidelity of delivery. Question about uptake, but the delivery was constrained. And we could understand, what are the people are getting. We can turn on and off different components. And I think that really lends itself to some of these adaptive type designs, just-in-time adaptive interventions. We've done some N of 1 trials to look at what might be specific intervention components or intervention aspects for individual people. We had a project that I worked on when I was at Northwestern called IntelliCare, where we built a suite of mini applications for depression and anxiety. And there were 13 different apps that were focused on different behavior change strategies. There was a cognitive restructuring app. There was a goal setting app. There was a behavioral activation app. There's an app that I helped develop that was one of my favorites called My Mantra, which I referred to as like the Pinterest to cognitive behavioral therapy. So you would come up with these self-affirmation phrases, and then you would go find pictures on your phone or on the internet that would represent that phrase, and they would send you push notifications of that throughout the week. Like, I am strong, I am successful, I'm resilient. These things would be coming at you through that app. And we were trying to really look at how we could recommend specific apps within that IntelliCare suite to specific individuals. So I think personalized medicine is another thing that becomes really possible when we have these more modularized treatments that we can really understand what a person's being delivered.
It's a little bit like the DBT for depression, the way you're describing it. Marsha Linehan always described DBT as, she would say, I was just taking everything that I could find that worked and I was putting it together into one treatment. And it sounds like that's sort of what that's doing, but from a digital app perspective. What do you think? I guess I'm curious, how did you actually see people using the customization? I'm just not like even scientifically, just like what was the user behavior when they're presented with all these choices? What were some things I guess you learned about how people customize, what worked for people, what didn't, or what did they like or not like?
Yeah, I think what was really interesting in the IntelliCare study, and this was actually contrasting to a study I had done about a decade ago where we were working with an online smoking cessation platform. So on that smoking cessation platform, we had different intervention components that they could pick. And what we found is most people in that, they just picked everything, which is actually kind of a good strategy because it's like, why would I not take it now when I can see if it works for me and continue to use it? But in IntelliCare, we did see that people kind of slowly added apps, and that usually people plateaued around 4 to 6 different applications. So it's not that they just stuck with one. It did see that they saw some benefit in having a couple different things available to them, but we didn't see a lot of people who were like using all 13 like long term. And that there were clusters of different interventions that seemed to benefit different types of people and that people stuck with. And we called them, based on 2 of the apps that we had, the daily feats cluster and the day-to-day cluster. And so daily feats was a goal setting app. So you would log on every day and you just check off some simple things that you did. I got out of bed, I took care of myself, I made good choices. And then you would go on throughout your day. And those apps in the daily feats cluster were apps that were a little bit more like that. You were doing more active engagement with the app, even if it was brief. Day to day was an app that you would have some lesson content. And we had 4 different weeks that were around different stuff: gratitude, cognitive restructuring, problem solving therapy. And each day you would get pushed multiple different reminders to use some of those. So it was a little bit more of like a passive, like, I'm going to be living my life and I'll be getting these tips that are going to be coming through me. And all of the apps that were in that cluster were kind of more of those receiving content or receiving things pushed to you. So it seemed like there were some people who really liked the kind of active apps that they were using in short bursts throughout the week, and some people who liked the apps that were really pushing them content. And I found that really interesting. It's not suggesting that there's one right way to engage people, but there might be different patterns that come out.
It's really interesting, and it makes me wonder if there's a middle ground. So in a way, when you have sort of pure choice, people choose what they want. There's lots of different reasons why people could choose those things. Like on the one hand, it works for them. Mm-hmm. On the other hand, maybe it's also the thing that's easy. And you wonder if, an adaptive strategy would be, and this comes from research I remember Ron Smith at University of Washington doing with Yuichi Shota, where they would give personalized feedback about real-time stress and coping related strategies. And the exemplar feedback I remember them saying was, you could say to somebody, hey, I noticed you're using distraction a whole lot when you're stressed, and it's not very effective. And yet a couple of times you reached out to a friend when you were upset, and that was really effective. Your mood scores got way better, but you don't do that a lot. And it just makes me wonder about, how and I'm sure this happens in adaptive trials. It just makes me wonder about that balance between personal choice and personal efficacy, and how you could work to find that sweet spot of giving people freedom while also giving them a little bit of scaffolding or a little bit of challenging to find the things that are most effective for them. I don't know if you have thoughts on that.
Well, I think that sometimes people choose things not because it's best for them. And we see that in a lot of places. But I think that choice is important. So there might be a right balance between giving them enough stuff that they feel like they've chosen to keep them engaged, but then enough stuff that is the stuff that is good for them. It's like, how do we balance the chocolate and the broccoli? Don't make the chocolate covered broccoli, but have them both present there to have sort of a balanced diet, so to speak, in the interventions that they're receiving. It's really interesting questions. And I think that some of these adaptive designs or other methods that allow really granular evaluation of these things is really the way to kind of go about understanding and unpacking those things. But I think, I've argued in a lot of places that we really need like a science of engagement related to digital mental health. And I think that's one aspect that should be thought about a lot more as we sort of unpack that engagement aspect.
Yeah, for sure. We called those adventure bites in my house when the kids were little. You got to take an adventure bite of that broccoli before you can have more of your chicken nuggets. And now our kids are 4.5 and 7.5, and it's all chicken nuggets from here on out. But there was a point we were really committed to adventure bites, and it was moderately effective. Yeah.
I should start to pull that with my students and trainees who work with me and encourage them to go on more adventure bites for their research programs.
It does sort of strike me though, so it's making me reflect on our conversation earlier, where even therapists oftentimes will just go to whatever component that they're comfortable with doing. Oftentimes, like in trauma-focused cognitive behavioral therapy, for instance, at least the conventional wisdom is that trauma narrative can be something that therapists themselves are kind of afraid of delving into. So maybe they focus a lot on relaxation or psychoeducation or cognitive restructuring, things that they feel a little bit more comfortable with. And by the use of really good measurement-based care, where you both look at how the patient is improving over time, but you're also looking at what components you're delivering and how that's associated to whether they're improving over time, that is supposed to help change the therapist's behavior. In this case, though, we're bypassing the therapist. And I love this idea that Kevin's talking about of at least kind of giving some information to the client, the user of this digital mental health intervention about like sort of what are their behaviors with the app and what's actually working versus maybe what they're gravitating towards. Interesting thought.
I want to ask a follow-up about you talked in the a little bit ago about bad actors in remote trials and sort of bots and bogus participants. We just finished a big study in my lab where we were supposed to be recruiting people in person in the Puget Sound area of around Seattle, and then COVID hit, so we switched to remote, and we had to deal with a ton of bots and fraudulent participants, and we even had legitimate Nigerian scammers that made it to an EMA portion of our trial. We had GPS information on their IP addresses and built maps of where people were pinging from, and we literally had a couple of people doing EMAs from Nigeria. Not that many, but I'm curious, what advice would you have for listeners who are engaging this kind of research? What have you learned about how to identify, prevent, screen against fraudulent participants? Because I think, like you said, I think it's a huge issue for the field, and we need to be taking it seriously, at least trying to do something about it.
Yeah, I think the more steps you have involved, I think the better to be able to find some of those potential fraudulent participants and screen them out. Now, I think one of the challenges is, I imagine you guys do this too, like recruitment is such a hard thing. And so usually we try to make it easier for people to get into our studies. And so adding some additional barriers might actually prevent people who are real people from participating. I think we've been looking for different signals, checking IP addresses, locations, making sure we verify addresses or phone numbers. Like if they give us a phone number, let's actually call it back and see if someone picks up and make sure it's the same person whose name. I think we've seen some people try to produce different accounts with different names and they can't keep track of which name that they had. Asking people to provide some different autobiographical information, making sure that there's good attention checks in some of the different measures that you do. We usually, in a lot of our studies, will throw into questionnaires like attention checks where it's like, make sure you answer this a 4 or something like that to be able to actually screen like manipulation checks. And so sometimes for the eligibility criteria, we've had that they've had to meet certain attention checks to be eligible for the study. One study actually we've been doing recently where this was a problem, we actually even had a question where it was like, verify that you meet the status and reminding people like, don't, if you are fraudulently representing yourself, that is actually not legal. So don't do that. And we have had people then endorse like, no, this is not actually me. It's like, okay, it's an easy person to rule out. So I think there's a variety of different things that one can do. But I do think there is a trade-off between putting up some additional barriers to real participants. And again, recruitment is always a challenge in trials.
Yeah, I just want to say to our listeners, like if anyone who posts any sort of study on social media, even if it's an unpaid study, you're going to get hit with fraudulent responder. Like it's just going to happen. And sometimes it can just be 1 or 2 people who are submitting hundreds upon hundreds of surveys, as you mentioned, Stephen. So we've had this situation happen as well. And I also want to just kind of put it in context. I mean, as Kevin said it in our case, we were able to identify that people were responding from China. In many parts of the world, we think $20 for a survey, $10 for a survey. How could people bend over backwards to get this little bit amount of money? But that's like a weekly, monthly salary in many parts of the world. And so we have now this kind of global outreach for participants that's possible,
Mhm.
but the disparities that are, worldwide really create a huge incentive. And I don't blame them. I mean, people are kind of doing what they can to get by. And so that's out there, but it has made our life very difficult. I'm curious, Stephen, what you think about some of these places like MTurk and what's the other one? Starts
Prolific. There's
Prolific people
several.
use a lot.
Yeah. What do you think? What do you think about these places for kind of preventing fraudulence?
Yeah, I think different recruitment platforms have different protections against that. I was going to say we don't use any MTurk studies recently. I actually would have to think about if that's true. It's been a long time since I've personally run like an MTurk study. We've used Prolific a little bit. I think it helps solve it somewhat, but I still think that there's still onus on the researcher to put in some of these additional checks. I think some of them do a better job than others. I think definitely if you're restricting to US based samples, that solves some of these problems. I think some of it's also the question that you have, and there might be some questions that are very reasonable to look at in a population that is more broadly recruited, but other things that you might want to look for a more specific sample and just like really contextualizing the participants you have in thoughtful ways.
Yeah, I mean, even, the advice that you might get on using any one, online panel or online sample, it's going to evolve. And like you
Mhm.
said, it depends on your context. It depends on when you're trying to recruit. There's times where you'll see on social media that, all of a sudden everybody's getting fraudulent participants run through Prolific, like something changes in the pool or something changes in the algorithm. And I did say, even with attention checks, and my lab's done a little bit of research on attention checks. And one of the things we started realizing was that when you use them, you got to be careful to, when you use an attention check, if you use it to exclude people, you're assuming that every attention check works the same way and it
Mhm.
works perfectly to discriminate between people who are conscientious and non-conscientious respondents. And that, people have interrogated those assumptions that's not always true. There's a great paper by, I believe it's Jeff Curran, called I Am Paid Biweekly, but Not by Leprechauns. And it's a qualitative investigation of people's survey respondents' responses to attention checks. And it highlights the assumption that sometimes people are super conscientious and they think it's a real survey question. And so they're trying to
Mhm.
answer honestly. And so it really depends. There's a lot of assumptions that you embed within those attention checks, and we have to be careful about how we use them. I mean, that's all to say it's difficult and complex, and there's no easy answer. And whatever the answer is right now might change over time.
Yeah, it seems like a bit of an arms race in terms of, every time we develop something new, then people will develop some way to get past it. All right. Well, all this has been a great conversation, but this isn't the real reason why we invited you to come on the show, Stephen. We invited you on the show to play a new game that we're testing out. We figured you would be a perfect person for it, given your prolific postings on what was once Twitter, is now X. And this game we're calling Don't Get Me Started. What we're gonna do is we're gonna give you a topic, and we just want you to rant about that topic. And if you can rant for a sufficient number of points, then you'll win the prize. Kevin, do you want to explain what the prize is to Stephen?
Well, as Stephen knows, because he is one of our oldest and most cherished listeners, sorry, Stephanie, the prize is that I'll write your away message for your email the next time you're traveling, or whenever you choose. If you win, I will write a hilarious and personalized out of office message for you. So you'll just have to give me a few details about the style of out of office message you like, and I will craft one that is both professional, insightful, deep. It'll make you laugh. It'll make you cry. It'll be better than the live action version of Cats.
Well, I'm very excited because I'm headed to Boston for Anxiety and Depression Association of America next week. So there's a lot riding on this game here.
Fantastic. All right. So I can introduce the topic. And so again, you're going to have 2 minutes, and you're going to your goal is to earn 10 points over this 2 minutes. And the way you earn points is by making insightful, quotable, impactful statements.
Angry.
We're definitely looking for anger about this topic. So the topic today is about youth and social media. There's been a lot of press about the negative impact of technology on mental health. Johnathan Haidt has a new book called The Anxious Generation. It's been sparking I think a lot of conversations on social media as to the sort of quality of the research that's underlying the case they're making. In fact, in Mike and I's home city of Seattle, the Seattle Public Schools has filed a lawsuit based on, I think, a lot of this research or this contention that social media is causing mental health problems in kids has a negative impact on kids. So we'd like to hear your thoughts in a 2-minute rant about youth and social media. And Mike and I are going to ding every time you make an impactful point. So I am completely unprepared for this. So I'm getting my timer to 2 minutes. All right, 2 minutes and go.
Oh man, don't get me started on this. I'll say if I've learned anything as a psychologist, it's that there's always just one cause for any issue. So it's got to be entirely social media. I get asked this a lot actually, and they're like, well, if it's not social media, what is it? I don't know. Global warming, political unrest, economic uncertainty, the fact that we live in this world that is just increasingly hostile towards everything. I think all of these things are problems that are true in terms of growing up as a youth. I think if we look at the data in terms of the relationship between social media and youth mental health, most of it's correlational, which means that maybe people who are experiencing mental health challenges use social media differently. If you go in with a depressive mindset, I wonder what type of things you're putting on your feed. When we ask kids, there's actually a lot of kids who say that they're helped by social media. There was a large study that was done by Hope Lab in collaboration with some other folks where about a third of the kids said they were helped, about a third of the kids said it made no difference, about a third of the kids said they were harmed. And when you talk about like what they get out of it, they connect with people like themselves and they form affinity groups and they find their interests. And it lets nerdy kids like me growing up find other people who like Star Wars. Star Wars was not cool when I was growing up. So now it is. It's like, wow, this is amazing. I think there's a lot of, there's some experimental evidence, but the experimental evidence is somewhat small, specialized groups. They're paying people to participate in these. When we look at studies, they're often using self-report data of social media. So they're asking kids like, how long are you spending on social media platforms? I actually had a student who looked at this recently and she did find a small negative impact of social media, but you would have had to sort of increase your social media use by 10 hours a day to go up one standard deviation. It's like, okay, like use 10 more hours of social media. How's that going to happen?
Ding. Oh, so, and yeah, that is our 2 minutes. Thanks so much. I am completely convinced that I'm not going to let my kids ever get a smartphone or get on MySpace as they age.
Well, you definitely should not let them get on MySpace because Tom is a sketchy guy, and I do not want them to be friends with him.
All right.
Wow, that was amazing. I'm just gonna say that as our first player of this game, I'm really impressed. I'm really impressed.
That was high quality. And I think I officially counted 9 dings, but I'm pretty sure I think I gave you a double ding for a measurement or effect size ding in there. So I think that's gonna round that up to 10. So congratulations, Stephen Schueller. You have won my crafting of your out of office message for your next trip. So all you need to do is send me an email saying, hey, I'm going for these dates, and I'll send you a couple of options for your out of office message, and you can choose.
I will get it to you for Boston next week.
Fantastic. That will be wonderful. Well, we did want to get your impressions and you already shared a lot of them. Where do you see the role of technology in creating positive change? There's a lot of talk about the sort of negative impact of technology on kids. But what do you see the role of technology in positive change? You as you said, you started off as a positive psychologist, so draw on those roots.
Well, I think that one of the ways just to get more resources out there to people in needs, and when you look at who use some of these different online tools, Crisis Text Line, Mental Health America, the population skews young, it skews LGBTQ, it skews racial and ethnic minoritized individuals. And so I think these are a lot of the folks who are not able to go get support in their areas. I bring up a lot is some of the justification for why I do the work I do, just the lack of mental health professionals that are out there. 1 in 3 counties don't have a single licensed mental health professional. And I think the additional thing to think about is like, okay, well, even of those that do, what are the odds that, the mental health professional that's in your city in rural America is going to be gender affirming to a gay teen who's trying to figure out, where his, some of the struggles he's going through. And so I think for a lot of people, the old model was that you're stuck with whoever is, in your area. And in some places, California, maybe that's fine, but in other places where there are very few mental health providers, I really worry about that. And so I do think opening things up more broadly, making more scalable services, making things available, I think is a positive thing in terms of being able to create opportunities for young people to receive support, to find other people like them, to connect with other people in need. When we ask teens, like, why do you go online to try to find health information? Oftentimes it's to find other people who've struggled with the same things that they're struggling with. And I think that connecting with other people with lived experience is powerful.
But surely, Stephen, social media is completely addictive.
I think that one of the challenges is like we haven't grown up with it. I don't know if this is the best metaphor, although Kevin, I know you do research in substance use, but I've heard some metaphors or things, people talking about this of, like alcohol as an example of like that we have grown to have social norms around alcohol. I'm always very impressed when I go to Europe. I've got German family, and whenever someone brings a 6-pack of beer, there's always a non-alcoholic beer in that 6-pack because whoever's driving that day, that's their beer. And I think that if we sort of better understand some of the norms around how this tool can be used and like when should we use it and when shouldn't we use it. I'm not saying let's sit on social media all day and doom scroll on Instagram, but there are benefits that come from doing it. And like, maybe we do have to think about better scaffolding or structuring to teach people how to use these tools effectively. I just think that the abstinence only, let's take social media away from everyone and unplug. One, I think that ship has sailed, and two, I think there are a lot of benefits that people get from social media in different settings.
Wow, a complex view with pros and cons. You're truly a person from another era.
It's going to make all the headlines because we know that nuance really sells, and that buzz click titles are things that nobody likes and no one will click on.
I remember my first year of grad school, Paul Caroly taught us a class on research methods. And one of the most quotable quotes he had from that class was, "You never get famous by saying things are complicated." And that's sort of been my mantra for most of my career, that we're a psychologist, everything's complicated.
All right, so Stephen, what are one or two of the most important implementation science publications that you feel that any budding implementation science researcher should read?
Well, one paper I've really enjoyed recently, and it ties back to something we talked about earlier, was a paper that Enola Proctor published on the FAST, or the Framework to Assess Implementation Speed. Enola's point in that paper is one of the things that led to the creation of implementation science. And the goal of your podcast is to reduce that 17-year gap. And, we're really trying to figure out, are we actually doing that? And I think that in technology, we really do have a potential, as you mentioned earlier, to get things out quickly and to get them to people, and really understanding how we can appreciate and measure the speed at which things are reaching people, I think is a really interesting thing that we should be looking at. So I thought a lot about that paper that Enola's published lately. I'll give a shout out to one of my favorite papers for budding implementation scientists is Jeff Curran's Implementation Science Made Simple. I love that paper. I send it to everyone. That just language around the thing and how we get people to do the thing as we're using earlier, I think is a really useful frame to think about this area.
And no one ever cites my paper on how to make implementation more complex and difficult. I don't know why that is. Any shout outs to any special people in your work or your personal life?
Well, I guess I have to give a shout out to Griffin, Ellen, Riley, my triplets. They're amazing individuals and super fun, and I'm glad we made it 8 years together.
Excellent. And I know you're on social media. Where are some of the places people can reach you? And what's your handle?
X at Steve Schueller, which is actually kind of funny because no one really calls me Steve, but Stephen Schueller was taken. So it's always funny when I run into people who only know me through social media and X, and they will be like, "Steve, how's it going?" And very few people, actually, Marty Seligman called me Steve all the time. But I think that was his way of, if he's Marty, I'm Steve, and that's how we connect.
Have you attempted any switch over to Blue Sky or any alternate social media?
I have a Blue Sky account, and it is Stephen Schueller on Blue Sky. I just still find that there's more of a conversation going on X. So as much as I don't want to give Elon Musk my clicks and my attention, I find myself there.
All right. Well, thank you so much for being on the show. It's been super, super fun to have you. And yeah, this has just been such a wonderful conversation. I'm sure our audience will love it.
Happy to be here. This was awesome.
Thanks for coming on, Steve. We really appreciate it.
Thanks so much for listening. Our show now has nearly 6,000 downloads. But honestly, how many of those are fraudulent participants? I'm sort of, but not really, on the social media platform formerly known as Twitter at @ThatISPodcast, and Kevin is at KMKing_psych. Kevin is also on Blue Sky at Kevin M. King. All of the comments and opinions expressed during today's show are our own. They are well-reasoned and insightful, and therefore are probably not endorsed by our grant funders or employers. Thanks for listening. On behalf of Kevin King, we'll catch you next time.
I am strong. I am successful. I'm resilient.